This is a question that I ask myself every day. We'll get into that later, why I ask myself this. And I think a lot of patients with systemic sclerosis also ask themselves this question if they haven't had the particular food before. I'm Arnold Postlethwaite. I'm from University of Tennessee Health Science in Memphis. And I'm a rheumatologist and have done research both at the basic and translational level in systemic sclerosis and rheumatoid arthritis, which is sort of the antithesis, if you will, of scleroderma, in that the rheumatoid arthritis, the problem is tearing up too much connective tissue, particularly in the joints, with the collagenase and the enzymes that degrade the collagen in connective tissue. And in scleroderma, the connective tissue accumulates too much, and there's actually a problem with these enzymes not being able to degrade the collagen, as well as overproduction. We've described throughout my career a lot of the factors that are made by the immune system and inflammatory components that drive both the production of collagen as well as the degradation of collagen. So it's interesting to see this whole scleroderma field evolve, and I think potential treatments are certainly in the pipeline for this disease. But I wanted to talk today about a very common problem that we see with the gastrointestinal tract involvement. I know there's some other talks being given by this that are focused more on the actual portions of the gastrointestinal tract and what the problems are. So we won't spend a lot of time on that because I want to spend more time on number 2 and 3. And we want to talk about the GI and extra GI symptoms of celiac disease, which is also an autoimmune disease, and also the sort of cousin of that, which actually now is beginning to realize to be perhaps even more common than celiac disease, in which you don't have the antibodies or the pathology in the gastrointestinal tract of celiac disease, but you have this sensitivity to gluten, and you have a lot of the intestinal as well as intestinal effects of gluten and other compounds. It isn't always gluten they're finding, but other compounds also, particularly the FODMAPs, are able to trigger some of these symptoms. And I think at least a few of the patients that I see in our clinics at the University of Tennessee I think may have this, and some of the foods that they say they have to avoid would suggest this may be going on. So there is very common gastrointestinal tract involvement, and we refer to this as GIT. So as many as 90% of patients will have the involvement and symptoms at some part of their disease. And it's the most common cause of morbidity, or just not feeling well, and a lot of problems just with daily life. And actually the third most common cause of mortality. The gut can perforate, you can get sepsis, etc. From this. The frequency ranges of the GIT symptoms was evaluated very, very nicely in a very large study in England, 402 patients. And they used the UCLA SSC GIT1 questionnaire, which is Dr. Kahana and others at UCLA developed. And this assesses the frequency of the reflux, distension, diarrhea, constipation, abdominal pain, and the effect of symptoms on social functioning and well-being. And when they did this survey of their 400 and some patients, 72% were taking medications for gastrointestinal symptoms, which were acid suppressants, prokinetics to stimulate gut motility, and laxatives, and 94% still reported having, although in spite of taking these, had upper and lower GI symptoms. These symptoms occurred at least weekly in 97% and daily in 15%, and only 3% reported no symptoms. And so the frequency of these is nicely graphed on this slide. And so the white portion of each one of these bars is no symptoms whatsoever in terms of the percentage of the patient population, the 400 and some patients. And in 1 to 2 days a week is the gray, and 3 to 4 days is more gray, and then sort of the black is 5 to 7, very common. And as you can see, the most common symptoms, at least 1 or 2 days a week, is in the reflux and the distension portion of it, with the rest of these being relatively similar in terms of the total percentage, about half patients having some sort of these symptomatology. So there was no significant difference in the symptoms they found between those that had limited cutaneous systemic sclerosis versus those with diffuse cutaneous systemic sclerosis. This is an interesting thing that they found. There's an autoantibody called anti-U3RMP, which was associated with more frequent diarrhea symptoms, and patients with pulmonary fibrosis, they also found, had less diarrhea and more frequently were taking acid suppressants than patients without pulmonary fibrosis. So this is a questionnaire that was used in a lot of studies coming out of Canada, and it's very interesting, and this is on your reprint of the slides, and I won't spend time on this, but this really is sort of the things that you would, if you participate in some of these surveys or studies, these are sort of the type questions that would ask you to have, and I think many of you who have GI involvement will identify with some of these problems. So, and then I want to just go over this very briefly because, as I said, this has been covered in other talks at this conference, and so I really won't spend a lot of time, but we talked a little bit also in my talk yesterday about some of these. So the oropharyngeal dysphagia, characterized by regurgitating food in the nasopharynx, usually a few seconds after beginning to swallow the food. It's caused by dysfunction of the constrictor muscles in the larynx and can cause voice problems and hoarseness, and the difficulty swallowing saliva and drooling can sometime occur. Then the esophageal dysphagia, which is dysphagia localized to the upper esophagus and lower part. There's problems with propulsing the bolus of food and through the pharynx and the upper esophageal sphincter, which is a muscle in the upper part of the esophagus. There's it can be caused, there are abnormalities in the functions of nerves and muscles that occur, and later with thickening of collagen in the walls, this can come quite rigid and have to be dilated if getting really severe. Particularly lower esophageal sphincter sometimes will get fibrotic and stricture will occur. Gastroesophageal reflux, again because of the problem with the lower esophageal sphincter and as well as poor motility through the stomach. And then esophageal stricture, difficulty swallowing, feeling that you can't pass food, retrosternal pain right after swallowing, chest pain during eating, and regurgitation of undigested food are symptoms of this. And then the delayed gastric emptying or gastroparesis due to sort of paralysis of the stomach. And then there's this very serious complication that can cause bleeding, in which you essentially have varicose veins of the stomach. We call it vasculartasia. And these are very prominent veins and blood vessels in the stomach that you can just look down and see. And it sort of has the appearance of a watermelon when you look at the lining of the stomach, sometimes called watermelon stomach. And this can cause chronic gastrointestinal bleeding and resulting anemia. Then the small bowel involvement, both the large and small bowel, as well as the rectum and anus can be involved. Dysmotility is the hallmark of this. Just the smooth muscles do not have the peristaltic normal traction that they have to propulse the food through the small intestine into the colon and into the rectum. And then bacterial overgrowth occurs, particularly in the small intestine, where it should never have bacteria growing in it. This causes malabsorption of nutrients because the bacteria starts eating the food instead of letting the food get into the bloodstream and nourish the patients. And in the most severe form of this, you can have a pseudo-obstruction-like picture in which it looks like you have a bowel obstruction. But this really does usually not require surgery, but can be treated with prokinetic agents. And this can lead to severe malnutrition. So the bowel involvement and the colon is associated with dilatation of the colon. You can have air accumulating in the colon in excessive amounts called pneumatosis, and a pseudo-obstruction period, chronic constipation, sometimes diarrhea, fecal incontinence, and bleeding. So these are dietary recommendations because they're really very extensive. I'm not going to spend time going through each one of these, and they're on the handout, and these really just show that by and large you want to, if you have difficulty swallowing, small meals frequently during the day, you want to drink a lot of water. You want to sometimes sugar-free gum may help in some cases to stimulate production of saliva and also help to prevent dental caries. Soften food with oil, butter, margarine, or sauces, especially for wheat and vegetables. Moisten dry food like bread or crackers and liquid if you try to eat these. And get the desired consistency by adding water, milk, or broth, or thickeners such as cornstarch, flour, commercial infant cereal, or prepared, which can be prepared specifically. So the recommended foods of these would be easier to swallow would be these here, and the foods to avoid these sticky foods such as boiled rice, sliced bread, mashed potatoes, bananas, foods such as grilled meat, artichokes, asparagus, and dry foods and nuts, toast, potato chips, cookies, fish with bones, and meat with small bones, such as rabbits. I don't eat rabbit anymore. I used to in West Virginia. My uncle would go out and hunt. But I understand it's the big thing in Europe, right? Germans particularly like to eat rabbit. But apparently they have small bones. So anyway, so for gastroesophageal reflux, these are the recommendations. Again, drink plenty of liquids, small volumes, eat and chew slowly, eat soft consistency or pureed foods, avoid extremes, avoid butter or fat, use simple cooking, and set 1 or 2 hours after meals. This is very important because gravity will help propulse the food down. And this is extremely important. Elevate the head of the bed. And you should eat about 2 to 3 hours before bedtime. And the gastroenterologists say, and the pulmonologists who have interstitial lung disease from GERD, say that you need to have 8-inch elevation of the head of your bed. The whole bed needs to come up, not just this, the middle part, because if you do that, then you have a buildup of pressure in the abdominal cavity, and it pushes up the stomach up into the, and helps you regurgitate food back up through the esophagus. So the whole thing needs to be tilted, and it may be a little uncomfortable sleeping on it, but that is the best way to really decrease the regurgitation of food at night. I do this on my bed because I do have GERD problems. My wife also has it, and we've elevated our bed on blocks of wood. And it really helps, makes a big difference. When I come here to a meeting and I have to sleep on a flat bed, it's very miserable. I mean, it's terrible. I try to put pillows on there, but it never works. And I just, always want to get back to my bed. So these foods apparently are very bad if you have gastroesophageal reflux. And alcohol and all these beverages here, wine and vinegar, really good stuff here, actually is shown to make it worse and probably should be avoided as much as possible. And in stenosis, this is really more severe, and really you've almost got to go to almost liquid type consistency of the foods, and you avoid the solid foods, which are listed here pretty much as before. Sometimes you may have to resort to baby jars of food or commercial purees and other foods that are processed to really almost liquid consistency. The small bowel is when antibiotics no longer work, sometimes a feeding tube has to be inserted for nutrition at night. And constipation due to intestinal dysmotility can be treated initially sometimes with the laxatives, very gingerly though, and dietary fiber, but very cautiously administered. And non-absorbable carbohydrates such as sorbitol, lactulose should be avoided because they actually sometimes may worsen the symptoms of bloating and discomfort, and actually because they give carbohydrates help the bacteria overgrowth and make that even worse. So again, this has to be individualized to the patient where you have bacterial overgrowth, where some of these treatments can be used. The problem of restricting carbohydrates from the diet may reduce also intestinal fermentation by bacteria and help reduce the symptoms also. If lactose intolerance appears, it needs to be removed from the diet. And we'll get back to that because it is one of the problems sometimes with the non-celiac gluten intolerance type syndrome. And some studies have shown actually that there are probiotics naturally in some of these patients with small bowel involvement. And they actually are the lactobacillus or other probiotics. So the use of giving more of these is questionable in such a situation with bacterial overgrowth. Again, this is an area that needs to have further research. So the rest of this talk I want to spend on celiac disease and the non-celiac gluten sensitivity syndromes. So celiac disease is about 1% of the population and occurs throughout the world. It's an autoimmune disease. You have to have these particular genes, HLA-DQ2.5 or HLA-DQ8. These are susceptibility genes. There are a few susceptibility genes that have been identified in rheumatoid arthritis that are different, and in Crohn's disease and lupus, and a few in scleroderma, but less so in scleroderma. But these are highly associated. But around 20 or so, 30% of the population actually has these, but everyone doesn't get it. So there's got to be some other triggers for this celiac disease. So in celiac disease, the immune system is being directed, the T cells particularly, directed to gluten fragments, which are presented by these MHC molecules. These are called MHC molecules on antigen-presenting cells, and they are presented to the T lymphocytes and cause them to become activated. So when they see these in the intestine, they attack it, and it results in a sort of a flattening out of the intestinal villi, which are the little indentions throughout the intestine that help us absorb large amounts of materials because it really spreads out the surface area. The small intestine has a surface almost the size of a football field if you were to take it and spread it out. And that's how much these villus, they go up and down like this. And this has really been looked at and tried to mathematically quantitate this. And if you were to take the small intestine and we're able to stretch out all these villi and make it a flat sheet, it would almost cover a football field. So that gives you an idea of how large this surface area is. And in celiac disease, parts of this, particularly in the duodenum and sometimes in the small intestine, gets markedly atrophied, and you have difficulty absorbing the nutrients appropriately. So there's increased permeability because the damage to the villus and the lining of the small intestine, and so you have increased permeability and a malabsorption of nutrients. But I think what also happens is this allows gluten and in the non-celiac disease gluten sensitivity, other compounds to go into the bloodstream, and your immune system then attacks them when they get into the muscles and joints, and this is why you have aches and pains in your muscles and joints with the extra GI manifestations of these diseases. So this is sort of a summary of the pathogenesis. We have gluten, and it's incompletely digested. There's a modification normally of this transglutaminase 2 enzyme, and it causes these peptides to become altered and become immunogenic. And if you have this particular MHC genes, you then would get this immunity of the T cells to the gluten, and then you get celiac disease because they attack the tissues. So there's a balance then thought to be the intestinal microbiome is sort of at the bottom of this, and this allows various bacteria to overgrow and to contribute to this, as well as gluten, and may be other factors from the bacteria that trigger this celiac disease with the gluten sensitivity. So these are the bacteria that have been associated highly with celiac disease, and these are the most common ones up here, and as you go down, less and less common, but these are thought to be playing a role in the pathogenesis of and development of celiac disease. So although diarrhea is one mode of presentation, and in children it's very common to have this as a presentation of diarrhea and weight loss. However, and this is the thing that a lot of people, I think physicians don't realize, and they ignore this, in most adults, diarrhea is not the first symptom. But instead, there's many of the other non-classical symptoms, such as anemia, osteoporosis, dermatitis herpetiformis, abdominal pain, neurological symptoms, and psychiatric problems, infertility, aphthous stomatitis, which are sores that come in your mouth, and vitamin deficiencies. And as we mentioned, although these genes are very common, only a small percentage of people with these genes, 2 to 5%, actually develop the celiac disease. So the fact that there is this small fraction who have these genes develop it suggests there are other factors that trigger the onset, perhaps other viruses or bacteria that could amplify this response to the gluten. These are the recommendations by the American College of Gastroenterology 2013 guidelines to when should you work up and test for celiac disease, because it is requires some expense involved in getting the antibodies measured, and also during the endoscopy to look in the duodenum for and do biopsies of the villus and walls of the duodenum to make the definite diagnosis of celiac disease. And so these are the various symptoms. So if you've got a patient with signs and symptoms and laboratory evidence suggestive of malabsorption and chronic diarrhea with weight loss, diarrhea, postprandial abdominal pain, bloating, should be tested. There's strong recommendation for that. And with signs and symptoms, laboratory evidence, and as a treatable cause should be considered for testing for celiac disease. If you have a first-degree relative family with a confirmed diagnosis of celiac disease, it should be tested if you have any of these symptoms or possible laboratory evidence of celiac disease, such as one of the autoantibodies. And you consider testing asymptomatic relatives of first-degree family who have a confirmed diagnosis, like your brother or sister or mother or father. Celiac disease should be sought among the explanation for for elevations of liver transaminases, the serum aminotransferases, which we measure, and SGOT, SGPT, or also called AST, ALT. These are enzymes that are damaged when the liver or go up when the liver is damaged. We follow this particularly if you're on methotrexate, because methotrexate can cause these liver enzymes to go up. They also can go up in celiac disease. So for no other reason we have an explanation for that, we should consider celiac disease. Now, patients with type 1 diabetes, which is an autoimmune disease usually starting in children or early life, they should be tested for celiac disease if there's any suggestive signs of symptoms of the digestive tracts or signs or symptom laboratory evidence of celiac disease. Now, gluten is very interesting. The human species has only been exposed to this for about 10,000 years. Before that, humans used to eat primarily off the land, go out and kill an animal and get berries and grass or whatever they could eat, nuts, etc. But then about 10,000 years ago in the Middle East, they began to cultivate wheat and grow it as crops. And then this became very fashionable and found to be a very tasty type of food. And now it's one of the largest products in the world. Gluten has very high nutritional value, and it's also crucial for preparing high quality dough, to make breads and other pastries, etc. Gluten itself is composed of storage proteins that are in this part of the seed, the endosperm, from wheat, barley, and rye. And it provides nutrition for the germinating seeds. Now, wheat gluten contains two classes of proteins, which are the gliadins and the glutenins. Rye contains both gliadin and glutenin-like molecules, and barley contains gliadin-like molecules. So this is why barley and rye is also a source of issues with patients with celiac disease and gluten sensitivity. So these are the primary sources. All sorts of wheats up here are associated with gluten, rye, and barley. And my favorite peeve is malt barley. And this is what I have problems with, is the malt barley. I can eat matzah, which is pure, essentially wheat flour and water, and baked out in the bread. No problems. If I go to a French bread bakery and they don't use malt barley in their flour, I can eat that French bread all day, no problem. If I eat a bagel, which has malt barley in it, 2 days later I begin feeling terrible, I feel weak, I get aches and pains, my muscles hurt, my knees hurt, I get bursitis here, I get bursitis down here in the anserine bursa, my shoulders hurt, my neck hurts, sometimes I have little balance problems, I get tingling sensations in my extremities, and I don't sleep well at night. This goes on for about a week. Just one bagel will do that to me. And I've tracked it down, I think, to the malt barley, at least in the bread. So I avoid all pastries that have malt barley. And that's most of them, actually. The Intinman company does make, they call it a butter bread, or pure butter, and it's a little loaf, and it's very tasty. And it does not have malt barley, I can eat that. They also, Louisiana Crunch cake that they have, I can eat that. That doesn't have malt barley. And the cinnamon rolls, I can eat. But that's about all I've found that they make, at least on their packaging, that they say does not have malt barley in it. So this is a real problem, this malt. And for some reason, it's very tasty to add this to foods of various types. And it's widely used to increase the flavor and palatability of foods. So there are hidden sources of gluten, and oats, particularly if they're harvested, unless they're harvested separately from wheat, they also may have contamination with gluten. There is some issue and debate in the literature whether oats itself may have some other compounds that will aggravate celiac disease. And certainly I can't eat them. There's something in them that causes problems with me. It does the same thing that the bagel will do. The various sauces also have gluten added to them, so all the things that you eat, you think your salad dressing or whatever may have this in here, soy sauce. And fillers that are used in over-the-counter drugs or prescription drugs. Dietary supplements may have some gluten in it. And if food is prepared where there is gluten, such as pasta pot or toaster or deep fryer, you could get contamination. Although you may put in gluten-free bread or whatever, you may then get gluten if it's exposed in the same toaster or whatever. And then processed meats, they like to add gluten to processed meats. So these are the extra GI manifestations of celiac disease. And like I say, I have some of these when I get exposed to the malt barley containing foods and some other foods we'll talk about. So I don't have anemia. Reduced bone density, I think my bone density is good. It was measured about 10 years ago, it was okay. Arthritis, I don't have overt arthritis, but I have arthralgias when I do this. dermatitis herpetiformis, a particular type of eruption that occurs in the skin, and eczema and psoriasis is thought to be a manifestation also. Gluten ataxia, so I certainly have that sometimes. Feel like I'm unsteady on my feet sometimes. Even autism and schizophrenia is thought to be aggravated by celiac disease. Peripheral neuropathy, numbness and tingling, paralysis, whatever in the peripheral nerves. In children, it will lead to short stature unless it's treated early. Delayed puberty also in children. Hepatitis, those enzymes from the liver elevated. It's very not well understood why this occurs. And then cardiovascular manifestations are not really clearly associated, but are thought to be manifestations. And then involvement of the immune system with the spleen abnormalities have been considered also. And these others are less common. Involvement of the lungs, the kidneys, the pancreas, and dental problems directly attributed to it has also not been a strong association. Now, there are conditions which are more than 2 times increased in the general population with celiac disease. And then there are some that are less common. And so these are listed here. So symptomatic malabsorption, if you have that in a patient, or diarrhea with weight loss, chronic diarrhea with or without pain, chronic iron deficiency and anemia, metabolic bone disease, premature osteoporosis, postprandial bloating, all these, there's twice the incidence of celiac disease, and these are tip-offs that you probably should be considering testing for celiac disease if you have some of these chronically. And these are less common symptoms that are associated, and there's less of a yield by testing for celiac disease with some of these, because these have a lot of different things, such as chronic fatigue can be caused by a lot of things. This is really pretty much more for doctors to follow, but they really stress the importance of this the tissue transglutaminase A antibody, and the duodenal biopsy and the Gluten, the DGB Gluten antibodies are the 2 most common used right now, as well as the duodenal biopsy to establish the diagnosis. So if you have the duodenal biopsy is positive with low amounts of villi and villi atrophy, and you have the tissue transglutaminase antibody of the IgA type, these are both positive, then you have, by definition, celiac disease. Some of these others are more problematic in terms of establishing a definite diagnosis. Now, celiac disease and systemic sclerosis and other autoimmune diseases has been examined, and there's been some different results. And I think, particularly in scleroderma, the study that shows the highest association, which is around 7 or 8%, those patients were on a gluten diet whenever they had the antibodies and the endoscopy done. And that is absolutely essential to make a diagnosis of celiac disease. If you take a patient with celiac disease and put them on a gluten-free diet, about 6 months later, the antibodies will go away, and the atrophy in the villi will return to normal. So if your patient has been avoiding gluten because they just thought, this might be what I've got, and they come in and you test them, and they don't have the antibody, and then you don't go on to, if they do have the antibody, then you go on and do endoscopy and you don't have the atrophy of the villi, it could be because they have avoided the gluten. And so in this study, this really made a point of saying all the patients were on a gluten diet, and they had positive anti-tissue transglutaminase antibody, and the diagnosis was confirmed by biopsy. So I think this is probably the more valid incidence that we see in systemic sclerosis, around 7 or 8%. There was a study done out of New York Hospital in which they didn't say whether the patients were on gluten-free diet or on gluten or not. This didn't mention it, but they had about a 1% or even less incidence in there, just taking sera from the stored bank and looking at it. So in this particular study, 52 patients, they had undifferentiated connective tissue disease. So these are patients that have early some symptoms. There may be like lupus or scleroderma, maybe some myositis component, and we don't know exactly how to make a definite diagnosis of a given connective tissue disease, so we call them undifferentiated. And in these particular patients, the undifferentiated patients, 11% were positive for celiac disease antibodies, and all 4 of these 6 patients showed villus atrophy on duodenal biopsy, and 5 of these 6 patients showed a scleroderma-like phenotype. So maybe even early in pre-scleroderma, in the undifferentiated connective tissue part, there may be this increased incidence of celiac disease. So this is a syndrome which I want to spend the rest of the time talking about, because I really think it's more common, and this was originally reported back in the 70s and has been around, but it's very difficult to make the diagnosis because we don't have a test for it. There's no antibody we can test. If you do endoscopy, the GI tract looks normal, so it has to be done, make a diagnosis by association with triggering of the symptoms by food. And so this is a syndrome, non-celiac gluten sensitivity, with intestinal and extraintestinal symptoms that occur following the ingestion of gluten-containing food, that occurs in people without celiac disease or wheat allergy. So there is another problem with wheat in terms of some people will develop hives and really get an acute allergic reaction if they eat wheat. And then celiac disease is the other problem with wheat in terms of primarily the gluten. But these do not have either one of these. But what happens is the offending dietary protein may not actually be gluten. It could be some component of gluten or of wheat or grains that are different, such as protein amylase trypsin inhibitors have been described as one of the culprits. The prevalence of this syndrome is not known, but it's thought to be more common than celiac disease, which affects about 1% of the general population. I think in Australia there was a study which showed that 15% of the population avoided foods because they thought that they had this type of a syndrome. So the real incidence isn't known, but it's thought to be more common than celiac disease. The treatment is pretty much the same as celiac-type gluten-free diet. At least that should be tried. Now, it can be transient in some people. That hasn't been my case so far. And the gluten tolerance needs to be maybe assessed in patients with this periodically because it's not very pleasant going through life and not being able to eat a lot of foods that may have gluten in them, if you can do that. So the clinical presentation of non-celiac gluten sensitivity might be multisystemic, and there may be a variety of different symptoms. The time between ingestion of the gluten and the appearance of symptoms is usually short, but can vary from hours to days. And I think in my case it depends on the particular load of the offending compound in the food, but I have had symptoms occur 1 or 2 days later after eating. So you have to sort of think back. If you start feeling bad and aching all over, what did I eat 1 or 2 days ago that may have triggered this. So also sometimes abdominal pain are common and irregular bowel movements, and this does occur sometimes in my situation, irregular bowel movements for a day or so before I start getting the myalgias and arthralgias and bursitis and feeling weak and terrible. So these are the most common foods that have been associated with this non-celiac gluten sensitivity is gluten containing foods, lactose, milk protein. Fortunately, that's not a problem for me, and lactose doesn't seem to be. But this right here, these guys I think I have problems with some of these. The fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, the FODMAPs. And there's a website that you can go to, or if you just Google FODMAPs, you probably will come up with a website that has a list of foods that have high and low FODMAPs in them. And I think this The Stanford University has a website that also lists these. So the patients with this non-celiac gluten sensitivity complain of symptoms outside the GI tract, including headache or foggy mind, in addition to a variety of other extraintestinal symptoms and signs. This diagnosis should be considered in a patient with persistent intestinal or extraintestinal complaints who have a normal result of a celiac testing, and I've had this. I've had endoscopy and everything. Everything's normal, and I don't have wheat allergy, and I improve if I avoid most of the foods that don't have the malt barley in it. And so the other thing that's very important is the extra GI manifestations. Now, the intestinal ones are listed here. The very common ones are bloating and abdominal pain, and the extraintestinal ones are a lack of well-being. You just don't feel like, you don't feel well, and you feel tired. So this is very common in my situation if I eat something with malt barley in it. And also common is diarrhea, epigastric pain, nausea, and belching, GERD, aphthostomatitis, which I get, and alternating bowel habits, constipation, and then the common extra intestinal manifestations are headache, anxiety, foggy mind, numbness, joint, muscle pain, skin rash, and dermatitis. I don't have this, but I do have most of these other things. Then undetermined is actually passing blood in the bowel movements and fissures, anal fissures. I don't have these. These are not quite determined to be highly associated weight loss, anemia, loss of balance, depression, rhinitis, asthma. I think I do get the rhinitis for a couple of days with it. Weight increase, I don't have that. Intestinal cystitis. So I ate a can of potato chips, Pringles, on the way to West Virginia, driving. And I came down with, dysuria. I mean, it was painful to urinate. And my urine actually turned cloudy for about a week. So this was interstitial cystitis. That cleared up, like a week later when I did, avoided all this, these other compounds that would trigger this. So this is definitely a problem. And this is also seen in some people who have fibromyalgia. So I really wonder if sometimes our fibromyalgia patients also have this non-gluten sensitivity or non-celiac gluten sensitivity syndrome. So I think a lot of future research needs to be done in this area. So autoimmune disease in patients who have the non-celiac gluten sensitivity appears to be increased. In a prospective study that looked at the anti-nuclear antibody, it was positive in 29% of a total of 42 patients. 42 patients who had non-celiac gluten sensitivity compared to 7.5% of those who actually had celiac disease, and only 6% of patients with irritable bowel syndrome. So ANA appears to be a part of this, and it appears to be an autoimmune type of disease, or at least autoimmunity develops as a result of it. Autoimmune thyroiditis was the only autoimmune disease present in a prospective study group of patients with non-celiac gluten sensitivity, and were present again in a high percentage of patients. So in a retrospective analysis of bank sera on 131 patients with non-celiac gluten sensitivity, 29% or 29 cases had autoimmune thyroiditis, 4 cases had psoriasis, 4 cases had type 1 diabetes, 1 case had mixed connective tissue disease, and 1 case had ankylosing spondylitis, again emphasizing a higher incidence of autoimmune disease with this syndrome. The fundamentals of the gluten-free diet is you should avoid wheat, rye, and barley, including malt barley. And the safe grains, which are gluten-free, are rice. So I can eat rice Chex cereal in the morning. And these other grains are perfectly fine and don't have the gluten in it. I can't eat the oats, but I haven't tried all of these. I'm okay with corn. Then the sources of gluten-free starches that can be used as flour, which you can see in a lot of your gluten-free foods that you may buy. They can use these other components to make the flour. Now, I thought I was really, going to avoid this problem, but particular cookies that I bought was made with banana flour. And it was gluten-free, but it was made banana flour. Well, it triggered the syndrome in me when I ate a couple of those cookies. And so one day in the clinic, because I get hungry when I go in the clinic all day, I took a couple bananas with me one day. And I ate 2 bananas. And 2 days later, the syndrome was triggered. And so this is because of the FODMAPs, I think, that are in the bananas. And so these are the FODMAP carbohydrates that I think go hand in hand with this in causing a very similar syndrome. And so the FODMAPs, we talked what those are. The fructo-oligosaccharides, or the fructanes, are in wheat, rye, onions, garlic, and artichokes. Galacto-oligosaccharides are in legumes, and lactose in milk, fructose in honey, apples, pears, watermelon, mango. I cannot eat honey. I tried to eat about 4 tablespoons of honey one day as a way to get calories in, and it triggered the syndrome in me. If I ate apple peels, I also trigger the syndrome. So I think the fructose perhaps is what's doing this. Sorbitol also in apples and in these fruits, and in mannitol in gums and cauliflower mushrooms. So I have a problem eating gummy bears. I can't eat gummy bear candies. It triggers it also. And I think that's probably because of the mannitol and sorbitol. So I apologize for using myself as a reference for a lot of these things, but I'm really convinced and very interested in this topic because it's a very personal thing with me. Now, there are other things in foods that may cause some problems. If you look at the ingredients on the foods, which I do every time I buy something, I'll see what's in it. It's amazing, you can't even pronounce some of the compounds. But these are very common sources of natural food chemicals or added food chemicals that we have in a lot of the foods that we eat. And some of these cause problems with people, particularly if you have salicylate allergies and have problems with some of these. So this is how the FODMAP diet, at least in the clinic, is used. If you have the ability to look for malabsorption after eating fructose or lactose, they can give a challenge of this and do a breath test in which you measure the amount of hydrogen that's being expelled. And if the breath test is positive, then you proceed down a core diet with restriction of certain of these FODMAPs, and then these can be reintroduced later to see if tolerance has been reestablished for those. But then if you don't have this available, don't have this testing available for pure fructose or lactose absorption, then you can go on a complete restriction diet of all the FODMAPs and see again if this relieves the symptoms and perhaps reintroduce this later on. But in my case, I don't seem to be able to reintroduce some of these compounds back. But I know 1 or 2 of our patients in our support group in Memphis really think that this is very helpful for them to go on the FODMAP restriction diet. There are some problems long-term with nutritional problems with deficiencies, and this probably should be gone over with a dietitian to really see what might be added or supplements that might be added to replace vitamins or other nutrients that are minerals that would be very important. So I hope this has been a helpful sort of covering of the symptoms of the celiac disease and the non-celiac gluten sensitivity and the FODMAP diet, and this may perhaps be helpful. So I'd sort of like to get a raise of hands. How many of you think may have one of these syndromes, either celiac disease or non-celiac gluten sensitivity? And yeah, so that's about what we see in our population. So there's a very famous rheumatologist in Dallas who visited our University of Tennessee about 6 months ago, and he's very interested in what he's observed, that he just routinely now has his rheumatoid arthritis and lupus patients try a gluten-free diet. And he says, a not insignificant number of these people claim that they feel much better on a gluten-free diet. So I really wonder if it's, the non-celiac gluten sensitivity has increased in these patients, and this is what he's really seeing. So I think there's a real future here, particularly with the emphasis on the microbiome and the gut bacterial flora, and the role of diet in aggravating and potentiating and being associated with some of these autoimmune diseases. And certainly the quality of life is much affected if you eat these foods and you have a problem with it.